Idiopathic pulmonary fibrosis, or IPF, is a rare, irreversible, and relentlessly progressive fatal disease. It shares many hallmark characteristics with cancer, but is in fact deadlier than many cancers. Its progression is impossible to predict, and no two patients' trajectory is the same. There is no cure for IPF, but there are treatments that can slow its progression, helping to preserve patients' lung function and extending their survival. But to find IPF, you must first know what to look for. IPF is insidious and frequently misdiagnosed. Patients with undiagnosed IPF may have other respiratory comorbidities that can disguise its presence from pulmonologists. Over half of IPF patients receive an initial diagnosis of another, more common respiratory condition, and over a third receive 2 or more misdiagnoses. Suspect IPF when you first see its clues. A patient typically over 60 years old with dyspnea on exertion, non-productive cough, finger clubbing, or, most tellingly, Velcro-like crackles on auscultation. These signs of IPF should raise suspicion, empowering you to immediately refer your patient to a specialist center for a thorough diagnostic investigation. Diagnosing idiopathic pulmonary fibrosis, or IPF, is challenging. Guidelines recommend the input of a specialist multidisciplinary team, MDT. The MDT performs detailed clinical, radiological, and pathological assessments and are able to connect the results for a clearer picture. Consult with a specialist MDT, whether within your network, or reach out to others to ensure a correct diagnosis. If IPF is left untreated, as many as 1 in 5 patients annually will have an acute exacerbation, with a 50 to 90% risk of death within a couple of months. IPF does not wait. By being aware and vigilant, you can refer your patient at the first presentation of the key signs and symptoms of IPF to a specialist center and MDT. Your referral could significantly reduce the risk of death for your patients.